podcast all through COVID. We did a lot of, you know, communications so that they could play it over and over again. It's a very helpful tool. I don't see anybody. We had of course we had a few people signed up.
Well, it's just 7 o'clock now. It's
Looks like someone wants admitted.
Yeah. Greg, if you want to just set some ground rules at first, if people could mute themselves and use the chat function as well as turn their camera off, that'd be great.
Sure.
Which I will do too.
Sounds good. We'll wait another 2 minutes and then we'll get started. right, I think we will get started just for the sake of time. And thank you for joining us this evening. And again, this is also a session that is being recorded on WinCam. And so thank you to WinCam for arranging for that. Welcome to a webinar sponsored by the Winchester Department of Health as well as the Board of Health. I'm Dr. Greg Sawicki. I'm one of the members of the Board of Health and also a pulmonologist at Boston Children's Hospital. And I'm delighted to have the time tonight to spend and hear from Dr. Kevin Ard, who is an infectious disease specialist at Mass General Hospital and also a expert on monkeypox for the state as well as for MGH, and also happens to be a Winchester resident. So we are grateful that he has given us some of the time to talk through sort of what we've learned so far from a public health perspective, from a medical perspective about monkeypox. And we'll open it by having Dr. Ard present some information, and then we'll open it up for some questions and some discussion, which I think will be useful to those here as well as to the audience that may be watching this in the future. So with that, I'll just turn it over to Dr. Ard.
Thank you. It's great to be here. Thank you for joining. I very much look forward to your comments and questions. I'm going to share my screen to show a few short slides about monkeypox, and then we can have some discussion and questions and comments. So there we go. I think that's the correct view. If it's not, let me know. The monkeypox outbreak, I think in many ways caught the world by surprise. The first case identified in the US was identified here in Massachusetts, actually, at Massachusetts General Hospital back in mid-May. And this is really part of a global outbreak. The slide shows where things stand right now with the US outbreak. As of October 17th, there were 27,468 cases in the country. The US is the most heavily affected country. And then just 423 in Massachusetts. Fortunately, case numbers are declining. This is the epidemic curve for our state. You can see that things peaked in mid to late July and then have declined since then, which we think may be in part related to vaccination. I'll say more about that in a few moments. But first, an overview about the illness itself. Monkeypox is an infection. It's caused by the monkeypox virus, which is an orthopox virus. Another orthopox virus you may have heard of is smallpox, which has been eradicated. Monkeypox is actually very similar, but is not as lethal as smallpox. The illness caused by monkeypox includes a rash, and it can also often include fever and fatigue and malaise and swollen lymph nodes. It's important to acknowledge that most people have a mild to moderate illness. They don't require hospitalization, but they may have significant pain and discomfort. In a small number of people, often those who are heavily immunocompromised, have become severely ill, and a few have even died, but that is not common with this infection. The illness on the whole takes a few weeks to resolve, on average around 4 weeks. And we think that people with monkeypox are contagious from the time that they develop their first symptoms until all of their skin lesions have healed, the scabs have fallen off, and there is new healthy skin that has grown underneath. And again, that takes about 4 weeks for all that to occur. And what does monkeypox look like? Well, once the lesions reach a certain stage, they have a pretty characteristic appearance, and that's shown here on this slide. And especially in the upper left, you can see someone who has these lesions on their face. And they have this kind of round, almost donut-like shape with a central divot. That's the classic appearance. But before and after that stage, they can look like lots of other things, including pimples or bumps on the skin. And these images are also showing that people can have them inside the mouth. That's what is there at the bottom right-hand side. They can have them on the tongue. On other parts of the body as well, including the genitals and the rectum. So how is monkeypox transmitted? Well, far and away, the most common way is through close physical skin-to-skin contact. We think that's the major route of transmission in the current outbreak. That being said, it is also possible that monkeypox can be transmitted if someone has contact with objects or surfaces touched by someone who has active skin lesions from monkeypox. So examples of that would be towels or sheets, things like that. It is also thought that transmission can occur via respiratory secretions that are passed in the setting of prolonged face-to-face contact. We don't think that monkeypox is spread via what's called an airborne route by very tiny particles that remain aloft in the air, unlike some other infections. These other ways of transmission I'm showing here are not very common, but the illness can be passed from a pregnant person to the fetus through the placenta. And then for completeness sake, monkeypox can also be passed via contact with infected animals or animal products. That's not playing a major role in the current outbreak, but I mention it because prior to this outbreak, that is how most cases of monkeypox occurred in the US. Someone had contact with an animal or with a product from a country where monkeypox was more common. Those countries are largely in West Africa. So let's talk about testing, treatment, and vaccination. Testing is done by performing a swab of a skin lesion. Unfortunately, there's really no way to diagnose monkeypox if someone doesn't have a rash. So if they just have fever or fatigue, we really aren't able to diagnose the infection at that point. Once a skin lesion is present, a swab can be taken of that lesion. That can be sent off to the state laboratory here in Massachusetts or to a commercial laboratory where they will do the testing. Most people with monkeypox will have a self-limited illness that resolves without any intervention, and certainly without the need for hospitalization. But there are some treatments that are available. There is one drug called tecovirimat. This was actually developed and stockpiled by the government for smallpox in the case of a bioterrorism event. Again, because smallpox is also an orthopox virus, like monkeypox, and this drug is active against orthopox viruses, we think that it may work to treat patients who have monkeypox. And so if people have severe illness from monkeypox, or they are, say, immunocompromised and at risk for severe illness, then we can treat them with this drug. It's available through a specialized process from CDC called an IND. That stands for Investigational New Drug. And that's because we don't know for sure if this drug works for monkeypox. It's not approved by the FDA for the treatment of monkeypox. And so we need to go through this route to obtain the medication. There are many places around Massachusetts that have the ability to use this medication to treat someone with monkeypox if need be. And then, of course, an important part of response to infectious disease is vaccination, and that is the same with monkeypox as well. Vaccination is currently recommended for people who have a confirmed or a presumed exposure to monkeypox in the past 14 days, or people who have anticipated exposure, people who are at increased risk for monkeypox. And I'll share more about who is eligible in a moment. There are 14 sites that offer the vaccine around Massachusetts, and you can go to the Department of Public Health website to learn more about those sites. Mass General is one, but there are also 13 others. So who is eligible for vaccination? And this really parallels who has been affected by the outbreak so far. So this includes gay, bisexual, and other men who have sex with men, or MSM, transgender and non-binary people who have had a sexually transmitted infection in the past year or sought testing for one. It includes people who are living with HIV. About 40% of those with monkeypox in the current outbreak have concurrent HIV. It also includes people who are on or eligible for a medication that's used to prevent HIV, that's called PrEP, or people who've recently had more than one sex partner. It also includes people who've had sex at a commercial venue or at a large public event, people whose sex partners have had those risks, or people who anticipate any of those risks. And if someone is seeking vaccination, they don't have to explain which of these criteria they fit. They can simply say that they consider themselves at risk for monkeypox, and then they're deemed eligible. I should say that we have an early indication that the vaccine effort is effective. with unvaccinated people being 14 times more likely to acquire the infection than those who have been vaccinated. Right now, vaccination is not recommended for the general population or for healthcare workers, but really for the groups that I mentioned before. This is just a brief intro, and I'm happy to take questions or comments in a moment. But in summary, monkeypox is spread primarily by close physical contact with someone who has an active infection. Most people affected by the current outbreak have had a mild and a self-limited illness. A few people, especially those who are immunocompromised, have become more severely ill. Vaccination is available for those who are exposed or those who are at increased risk for infection. And unfortunately, case numbers have been declining in Massachusetts and also nationally, although it seems like things have plateaued a bit, and so there does seem to be ongoing transmission, although at a very low level. And so with that brief introduction, I'm now happy to take any questions or comments that you all have.
Thank you, Dr. Ard. And for those of you who are with us, please feel free to put questions in the chat or raise your hand. It's a small group, and unmute yourself to ask the question. But I'll start by asking a few questions. From just a symptom perspective, are there any other symptoms besides the typical rash that people should be on the lookout for if they have a concern around this infection?
Yeah, so people can have they can have fever, as I mentioned, or just feel generally unwell. Some people have had a significant sore throat or swollen lymph nodes in the neck. Some people have had rectal pain or difficulty with bowel movements. A few people have had cough or involvement of the lungs with some shortness of breath. In general, though, essentially everyone will at some point develop a rash as part of this illness. And so if those other symptoms happen first, they're usually followed by the development of a rash.
And can people spread or transmit the infection if they don't have the rash?
So we think that people can transmit the infection once symptoms begin. So that could simply be the fever, for example, the sore throat. We, as of now, don't have evidence that people who have zero symptoms are able to transmit the infection. And is there sort of a window after which the rash develops that transmissibility is less as well? I'm thinking sort of an analogy of, like chicken pox, when things scab over, then they're less transmissible. Is there sort of a window after that is less transmissible? Right. So, until all the scabs have fallen off and those spots have kind of healed over with a fresh layer of skin, they're still considered contagious. Now, they're likely less infectious or contagious than they were, when they had open lesions with draining fluid, things like that. But we do think that transmission is possible until all those lesions have scabbed over and then new skin has healed and formed underneath. You mentioned a little bit about this, but it was something that came up, I think, in the press when the monkeypox outbreak first started. Was this question of airborne transmission, especially given the fact that we're hearing a lot about airborne transmission and ventilation in crowded spaces for other reasons. Can you just clarify again if you said because you did mention that there were respiratory droplets, but how is that different from airborne transmission? Right. So when we think of airborne transmission, we think of infections. Tuberculosis is a good example, where there are these tiny particles that, someone may cough out or sneeze out, and they remain aloft in the air and can kind of travel far distances. So you don't necessarily have to be close to another person with that infection to acquire it. We don't think that monkeypox is transmitted that way. We think it's possible that it can be spread by these large respiratory droplets that tend to fall within a few feet of where someone is. And so in the scenarios where we think that respiratory transmission has been the source of an infection, there's been prolonged face-to-face contact between people, the infected person and the person who then acquired the infection. So we don't think it's spread via the airborne route. And in many ways, kind of what we're doing in healthcare settings parallels that. So for example, we don't use any special air handling in the rooms in which we see patients with monkeypox. And that's unlike other infections in which airborne transmission has been well documented. Another question around sort of the cases that we've seen here locally.
It sounds like the vast majority, if not all, have been in adults. Have there been reports of pediatric cases or any children getting monkeypox?
There have been a few children who have acquired monkeypox nationally. We think that's because they had close contact with an adult who had the infection. Most, or nearly all cases have been among adults, as you said.
And that brings me to a question that I've certainly heard from others in the community. Is there any risk for transmission in the school setting right now?
So I think that that risk is extremely low. Certainly if someone in a school had active monkeypox and they, weren't isolating and someone else had contact with their skin or other close contact with them, transmission would be possible. But we really haven't seen a significant amount of transmission in schools. And also because the cases have declined, there's simply less monkeypox out there. And so there are just fewer opportunities for transmission to occur.
And I guess the other question I think that comes up is, you said there's sort of shared equipment or sheets or towels. What about things like locker rooms and gyms or sports teams where they may be sharing different types of equipment, uniforms, etc.? Would that be a risk if there was an actual case?
So I think that's a scenario where transmission would be possible, but it's not really something we've seen much of. And so I think overall the risk is low, again, because there simply aren't that many cases right now. But there have been a few scenarios where there has been transmission from one person to another because of some sort of shared object. Again, those are few and far between and not the main route of transmission that we're seeing in the current outbreak. So overall, I think the risk is very low in those settings.
So do you have any idea why this summer these cases started to arise? Is there anything in particular that led to this particular epidemic?
So that is a great question. And interestingly, there have been a few experts who've been warning for years that the world was going to have a monkeypox outbreak. And there are a few reasons for that. One is that in recent years, including in 2017 and 2018, there were some large outbreaks in Nigeria. And so people began to think more about this as a possibility. And it turns out that compared to, say, several decades ago, there is much less pre-existing immunity in the population to smallpox, either through real infection or through vaccination. And so smallpox and monkeypox are similar viruses. Immunity to one may confer immunity to another. And so, say, in comparison to decades ago, the population was potentially more susceptible. And we also think that in a large part, this outbreak has occurred through a kind of a social network phenomenon in which primarily gay men have been affected. More than 90% of cases are among gay men. It seems that there were some settings in Europe at large parties and other events where transmission occurred and then allowed the virus to disseminate globally.
So you did say it was similar to smallpox, and as we know, smallpox was eradicated. So do you think that monkeypox can be eradicated, or is this a different type of virus that will just be around and potentially pop up in clusters in the future?
So that is a great question, and I'm not sure the answer to that. But I think that one thing that's different between smallpox and monkeypox is that we believe monkeypox has an animal reservoir. And that may make it more challenging to eradicate. Smallpox, as far as we're aware, does not have an animal reservoir.
Ruth, I see that you have your hand up. Please feel free to.
Good evening, and thank you, Dr. Ard. Thank you so much for the webinar. I have a couple of questions. I noticed that you said that there has been a decline in cases since July of this year, and I'm wondering if you think that's a significant trend or if it's kind of a little blip and what you think is going to have a lot of blips up and down in a very long pandemic. And then I'll wrap this into it. You could answer it at the same time. If you do think it's going to be a long pandemic, what circumstances could impact the future course of monkeypox in Massachusetts? Do you think there's going to be, should we be expecting new variants? Do you think it could become a mutated virus such that it does become airborne? Do you think we're going to see more around high travel times like holidays? So thank you. I'll be quiet.
Those are all fantastic questions. And I have to say, I don't necessarily know the answers. I do think that the decline in cases we're seeing now is a real trend, and it probably relates um, to we think vaccination. Again, there's evidence that vaccine decreases the risk 14-fold. Possibly also some behavior change. And of course, that aspect of it may wear off, and so there may be a rise in transmission later. I'm not convinced, and again, I don't know the future, but I'm not convinced that this is going to be like COVID, where we have multiple subsequent waves and frequent new variants. I may be wrong, but this virus seems quite different in many ways from that. I would say, though, transmission has not stopped. We are still seeing people who are newly acquiring this infection. I don't think it's necessarily going away, but I don't think that it's necessarily going to spike up to high levels again in the near future.
Thank you.
Go ahead.
Hi, thank you, Dr. R. This is very, very helpful. And so I just want to put it out there that I am with the Winchester Health Department. And so my question is around, I have a couple actually, but one pertains to the importance of isolation and quarantine measures. And if you could speak to that a little bit and perhaps the importance of that would be helpful. And then I'll ask another one after. Thanks.
Yes, that is so important. So people who are being tested for monkeypox, so they don't have a confirmed diagnosis yet, but they're being evaluated for it. And then, of course, people who have the infection are supposed to isolate. And that involves, essentially no non-essential contact with other people, certainly no close physical contact with others. If people, share a household with other individuals, we do recommend that they try to isolate as much as possible. That also includes within a home, not sharing things like towels, like sheets, trying to clean off and wipe down surfaces that may have shared use, like countertops and things like that. This isn't isolation per se, but I'll just mention it because it is an important point. We also recommend that people who have monkeypox, if they are contact lens wearers, that they don't wear contacts while they're recovering from the illness, because we do see a lot of what's called auto-inoculation, where people inadvertently touch a monkeypox lesion and then touch another part of their body and then transmit the virus in that way. And we've seen some significant infections involving the eyes. And so that's a bit of a tangent, but also something to keep in mind if someone has this infection. People with, and Jen, you can correct me if I'm wrong, but certainly people, as far as I'm aware, who do have confirmed infection, a public health worker does contact them to remind them and talk about isolation and ensure that they have all the information they need there.
Yes, and also reach out to their contacts and issue instructions around quarantine as well. These were terms we know so well from COVID, unfortunately. But my other question is, once you contract the virus, are you now immune for life, or are you subject to reinfection?
That's a great question. We think that people who've had the infection have durable immunity, at least for a long time. I'm not aware of circumstances of reinfection, at least among people who are immunocompetent, who have intact immune systems. And so I wouldn't say never, but certainly for a long period of time, we think that they're immune. This also means that people who have had the infection don't need the vaccine if they're otherwise eligible. They are not recommended to get the vaccine at this time. And I guess one thing you didn't ask about, but I think a common question is, what about people who had childhood smallpox vaccination? Are they immune to monkeypox? There may be some partial immunity, but there certainly have been people with childhood smallpox vaccination or remote smallpox vaccination who have acquired monkeypox in this and in other outbreaks. And so if someone does meet current criteria for vaccination but had remote smallpox vaccination, we do still recommend the vaccine.
Great, thank you.
So you mentioned that vaccination uptake was actually pretty robust here in the state. Do you have a sense of why the vaccine efforts have been so successful here in Massachusetts or more nationwide?
So I think on in one way, that vaccine effort has been highly successful, and that it seems like it's had an impact on the trend in cases. And certainly, we were at MGH were one of the first 4 sites in the state offering the vaccine, and the demand was immense. We were receiving hundreds of phone calls a day, vaccinating well over 100 people a day initially. On the other hand, though, there have been some problems with the vaccine effort, both here and nationally, and that is that although most cases of monkeypox now are among Black and Hispanic and Latinx people, most vaccinees are white. And so there are some important racial and ethnic disparities in vaccine administration that I think need to be fixed. But I think that to get back to your original question, Greg, there was a lot of there has been over these few months of the vaccine effort, a fair bit of outreach to populations that have been affected, a lot of word of mouth. And so I think many people who are at high risk for the infection have sought and been able to receive vaccination. I should mention that the vaccine is available at no cost to people. So whether they're insured or uninsured, they should be able to receive the vaccine without any copay or any other cost.
And you also mentioned a slightly increased risk among those who are HIV infected, but is that risk also increased for those who are immune compromised for other reasons?
So we think that other forms of immunocompromise may increase the risk of severe illness if someone does acquire the infection, but may not necessarily increase the risk of acquisition. That's still an area that I think we don't know a lot about, though.
And you talk a lot about transmission in sort of close context, but have we seen any transmission or cases in congregate settings like nursing homes, assisted living facilities, or any places like that?
I'm not aware of any significant outbreaks in assisted living facilities or nursing homes. There is actually a published case of someone who seemed to acquire the infection at an outdoor concert where they were kind of rubbing and dancing against a lot of people. So I don't know if you would consider that a congregate setting, but it was a scenario where someone seemed to acquire the infection in that way. But the ones that you mentioned have not been the sites of significant outbreaks.
Ruth, did you have another question?
Yeah, I do. If we have another minute. So you've mentioned a fair bit already about how healthy people can reduce our risk of contracting monkeypox and some of the things that we can do in our school systems. And between Jen Murphy and yourself, you've covered a fair bit about how we can deal with that from a health perspective, from public health perspective. So Truth in Advertising here, I'm on the Board of Health with Greg as well. I'm currently chairing that. And my question to you is there anything we haven't covered yet when you're looking across the state and how various municipalities are effectively preparing our communities and how we can protect our communities from the risk? Are there any other steps that we haven't covered this evening that you'd like to address?
I think the only other important thing to say is, this infection has predominantly affected gay, bisexual, and other men who have sex with men so far. And I think it's really important that we avoid discrimination and stigma associated with that. I think that that's you could see how that could easily happen. I think that the public health officials in our state have been very careful, to note that although that group has been disproportionately affected, that anyone who has, say, close contact with a person with monkeypox could acquire the infection, and also that, for example, vaccine is available to people with a presumed or confirmed exposure, regardless of their sexual orientation or their gender identity. So I think just making sure that, when we kind of educate about monkeypox and talk about it in our policies and our processes, that we guard against the possibility for discrimination and stigma.
It's an important point, and thank you, Dr. Hard.
So I have a couple more sort of small questions, but I think we started talking about this before the webinar. But I think just as in terms of the naming, is there a reason that it's called monkeypox?
The reason is that it was identified by some Danish researchers in the 1950s in a colony of monkeys, a laboratory colony of monkeys, and it was called monkeypox for that reason. It is not thought that the animal reservoir of this infection is monkeys. It's thought to be rodents. And so, in a way, the kind of name is unhelpful and somewhat inaccurate. Also creates the potential for discrimination and stigma. That being said, this is a name that's been used, consistently in the medical literature for decades now. There was a call to the World Health Organization to rename the infection, but there's no yet kind of consensus name for it beyond monkeypox.
And you did say about animal reservoirs just now, but can pets and house pets contract monkeypox?
That is a great question, and I forgot to mention this when someone asked about isolation. Mammals can contract monkeypox. So there is a well-described case of a dog who slept in the same bed as two people with monkeypox who acquired the infection. Transmission to pets does not seem to be common, but it is recommended that you isolate from your pets as much as possible if you do have the infection. We don't think that other types of animals, amphibians, reptiles, birds, can acquire monkeypox.
And you may have mentioned this already, but if someone is concerned that they were exposed, they are eligible to get the vaccine. Is there a window at which time that kind of information should be shared with health professionals?
That's a great question. Ideally, as soon as possible. We think, based on the experience during the smallpox eradication effort, that the vaccine can function as post-exposure prophylaxis, meaning that if someone has an exposure but isn't yet ill, that giving the vaccine can prevent disease. And we think that that's most likely to be effective in the first 4 days after exposure. Between 4 and 14 days, even if the vaccine does not prevent the infection, it may make it less severe. So the goal is to share it as soon as possible, ideally within 4 days, but up to 14 may still be impactful.
And this epidemic did start in the summertime where a lot of people were outdoors. Do you or your colleagues have any concerns that there may be another resurgence as people are more indoors over the next couple of months with the colder weather?
So I'm not concerned about that per se. We don't think of monkeypox as a sexually transmitted infection per se, but in some ways it's behaved like a sexually transmitted infection or an STI. Those increase in the summer. So I think a more likely scenario is that we'll see more monkeypox next summer.
And is there anything else that the state or local health officials, I know we sort of touched on this already, are doing behind the scenes to sort of help with ensuring that we have the necessary supplies, vaccines, treatments needed if there were to be further outbreaks?
Great question. The Department of Public Health has been extremely focused and diligent in trying to obtain as much vaccine as possible for our state, which is really distributed by CDC. They also have obtained that antiviral drug tecovirimat, and we in our practice have seen many of the patients who required tecovirimat in Massachusetts, and there's not been access to the drug and supply of the drug has not been a limitation, and so our public health colleagues have been really working avidly to secure both of those things for the state.
And have you found, obviously, as a referral specialist, that physicians or healthcare providers in the community are aware of what symptoms to be reporting to you or to public health officials in order to make timely referrals for these kinds of treatments?
I think people are increasingly aware, and there have been a few public health advisories that have gone out to all clinicians practicing in Massachusetts that I think have helped with that. But people who do see patients as part of their work, if they see someone with a compatible rash, especially if there are epidemiologic risk factors, should consider this. And the Department of Public Health is also very happy, I think, to to guide people through what they need to do to get the person an evaluation and treatment if need be.
So I think, Dr. R, this has been a very helpful discussion and presentation. And again, want to really thank you for taking the time out of your evening schedule to share this with our town, our residents, our health department, and our Board of Health. And we are fortunate to have you amongst our midst to be able to send these questions to if future questions do come up from our health department.
Thank you. I'm happy to help out, and thank you all for joining today.
And again, for those of you who listen live, thank you again for listening to this webinar sponsored by the Winchester Health Department and the Board of Health. And again, thank you to WinCam for streaming this and recording it for the future. And we are happy to take any questions at the Public Health Department or Board of Health in the future for any reasons. And again, thank you again, Dr. Ard, for your expertise and words. I think we are all set. Thanks, Kevin.
Thank you.
Janet, I think that was great. That was great. Really, I learned a lot there too.
Yeah, thank you so much. That was very helpful. Yeah, it was excellent.
Yeah, thanks for the opportunity, and hopefully it was.
You don't mind that we post those slides or anything,
No.
anything like that. There's nothing proprietary